You're listening to IHC's podcast.
Hi, folks. My name is Marissa. I'm from the Canyoncito Band of Navajos, and I am your comms coordinator here at the Indian Health Center. And welcome to our podcast, the IHC podcast. Today, we're going to be talking about traumatic brain injuries, TBIs, and I'm here with two lovely doctors. Go ahead and introduce yourselves.
Hi, my name is Sikina Mercer. I'm a family medicine physician. I use she, her pronouns. I don't have any tribal affiliations. I am currently a sports medicine fellow, so I finished my family medicine residency, and now I'm getting some extra training. And I grew up in the Bay Area, and that's where my family still is, up in the North Bay.
Hello. Hey, so my name is Matthew Sikina. I use he and him pronouns. I am an emergency medicine physician, and like Dr. Mercer, I am a sports medicine fellow. So I'm doing an extra year of training in sports medicine. I don't have any tribal affiliations, and I'm actually from Delaware, so from the East Coast. Lived a long time in Philadelphia, so yeah, very happy to be here.
Awesome. So the reason that we reached out to you today was because you were part of IHC's residency program. How long have you been a part of the program?
Absolutely. So I was fortunate enough to do my family medicine residency here at O'Connor, so I've been here for the past 3 years. This is actually my 4th year working with Indian Health Center, which is wonderful because it helps me feel super connected to the community that I'm living in. And a lot of these patients I'm still taking care of who've known me since I graduated medical school, which is really, really fun.
And I've been a part of IHC for the past year, just during my fellowship. But that being said, even though it's been sweet, and like Dr. Mercer, I think it's great because I feel very connected with the community around me, and I think it's a privilege to be involved in their health in a very personal and very fulfilling way.
Yeah. So you said you're from Delaware, and then
Yes.
you're again from
San Rafael.
San Rafael. Okay, awesome. What brought you to the Bay Area?
A beautiful little thing called the match, where you graduate medical school and you are just sent wherever you match for residency. But I applied to places in California because I wanted to be closer to my family, so I just wanted to come back and take care of the communities that took care of me when I was growing up. So
Awesome.
Yeah, and so like Dr. Mercer, so she mentioned the match. That being said, I'm very happy to be here. I was looking for a program that specifically had training for emergency medicine doctors in, for sports medicine, and this program just happened to be, one of the ones that I saw. And I had a personal connection too. One of my really close friends from medical school, she actually matched at the family medicine residency, and she was one of Dr. Mercer's co-residents. And she, when I was kind of talking to her about my interest in sports medicine and everything, she mentioned the program and she absolutely raved about it. And so I had to apply.
That's awesome. Yeah. Wow. I didn't even know about the match and just that whole process.
it's kind of a ridiculous process, and I don't think there's any other type of job that does that. But it worked out.
It worked
always
out.
works out.
Yeah.
Well, I'm glad, and we're happy to have you as a part of IHC's team. Whichever, if you plan to stay, or if this is just a stop along the ride.
We are very happy to be here.
Yeah, well, thank you. So today we're here to explore the topic of traumatic brain injuries in honor of TBI Awareness Month. So, did you have anything that you'd like to share about TBIs?
Sure. I think it's always important to start with a definition about traumatic brain injuries because we get a lot of information from the news and things like that, maybe in the media, and we want to try to break it down as much as we can. So a traumatic brain injury is actually a spectrum of different injuries that can occur with any outside force to the head that causes some effect to the brain. So a blow, a bump, jolt, even some sort of penetrating injury like a gunshot wound can count as a TBI. So on one end of the spectrum, you have a mild TBI, which would be kind of like a concussion. And then on the other end, you'd have the more moderate and severe TBIs, like maybe a brain hemorrhage or something like that, that's going to cause much more serious symptoms. So milder TBIs will have maybe milder symptoms, headache, maybe dizziness, brain fog, things like that. Whereas on the other side, you might be seeing more serious things like weakness, paralysis, maybe some amnesia and memory problems, and maybe even on the more serious end, coma or death.
And to kind of add to that, so TBIs, so like for example, concussion typically are associated, like in the common vernacular, we think about it associated with sports. But I think it's important to keep in mind that TBIs aren't always secondary to sports-related activities. So things like falls, motor vehicle accidents, even assaults can cause TBIs.
Yeah. My little sister recently, she's going to be a little sad that I'm sharing her story. Hopefully she can laugh at it. So she was running away from a bee.
Oh.
And she was pulling the car door open, and I don't know what happened, and she hit herself in the face with the car door. And she was like, I'm fine. But then she went to an event later that day where there was music, and she got a really bad, she got really nauseous, and she had a really bad headache. And then they had flashing lights, and she's like, I don't think I'm okay. So she ended up having to go to the hospital because she thought when she just bumped her head, it was nothing serious. But the bee caused her some trauma.
Oh, no.
Yeah, but luckily, like you said, it was the mild one, but she still needed to stay away from, lights and loud music for a little bit.
Super unfortunate, but also a really good reminder that sometimes those symptoms are not going to show up right away. Sometimes it's very obvious that you hurt your head, but other times like that, it just shows up a little bit later. So you always have to kind of be thinking about it, especially if it's like someone like a younger kid who may not be able to express their feelings or what they're feeling very well, or maybe an older person that might be a little bit more confused. It's always really important to keep an eye on them and watch for any, scary symptoms.
But just knowing that there's a big spectrum is kind of helpful, especially to folks like my sister who had an injury to her head, and she didn't think until she actually started to feel the symptoms that it was actually caused by it. She's like, oh, no way that I had that. I'm not, like you said, an athlete, and she wasn't, playing football. It was the car door, and there was a bee. Yeah. So what can someone do to avoid a traumatic brain injury? Is there certain things that they should stay away from, or just, good habits to instill?
Other than bees?
So certainly. So I think there's like a sort of standard kind of risk reduction that we can kind of all participate in. So things like wearing helmets, or when you're biking, when you're skating, when you're skiing, snowboarding, just wearing some sort of head protection is very important. Again, never drive under the influence of any drugs, alcohol, etc. And then also just keeping in mind locking up firearms, because remember, firearms, things like that can also cause TBIs, right? And so just kind of having healthy, safe habits is probably the most important way to reduce your risk of having a TBI.
But ultimately, we're humans. Things are going to happen. Car doors are going to come out of nowhere. But those are some of the things that you can do if you know that you're in a situation. Even driving in a car is accepting a little bit of risk, but somehow reducing the amount of risk that you're taking on can be helpful.
Yeah, and like you said, there's unexpected events too that happen. I just know so many folks with TBIs. My boyfriend, I was going between partner and boyfriend. My boyfriend, he had a pine cone fall on him, but it was still full of it was like a young pine cone, so it was very heavy. It was the equivalent of a very heavy softball landing on his head from a pine tree. And there's video of him at work when that happened. He's outside in the parking lot, pine cone hits his head, and he's like, oh, that was weird. He heard it, he didn't feel it, and then he walks into his job and he starts to feel something fall on his face, and it's, for the listeners, trigger warning, it was blood. And then there's video of him, because he didn't want to get blood on his white shirt. Oh. He just lay down on his stomach on the ground. And he's like, can somebody call the ambulance? And that caused him the other issues with the memory loss, the confusion, and then the changes in emotional state that were irregular. So those were things to kind of that were fun to go through with each other.
Sure.
But ultimately, I understood it wasn't his fault. Yeah. It was just the pine tree who had it out for him. So now he's very weary going underneath pine trees.
I mean, how many pine cone injuries do you treat in the emergency room?
Probably. I have not seen a single one yet.
Sure. You mentioned the change in emotions and emotional states. That's always a big one that I think we forget to tell patients about sometimes is if you feel like your mood swings are super irrational or something, it just doesn't feel right, that's a big sign of a concussion or some sort of TBI. And we see this a lot with little kids, actually, is they have these temper tantrums or they're just very volatile with their moods. That's a big sign for some sort of injury that we need to watch more closely.
Again, remember, like, especially little kids, right? It's hard for them to express sometimes what they're feeling, and so that's kind of the way they show their symptoms. And I think it's always important, in those cases to have a very low threshold to either see a doctor or seek emergency care in those settings, just because it's not something you want to miss, especially in a young kid.
Yeah, we were fortunate to get the warning from our physician that he went to at the ER, and they did let him know, like, hey, you may or may not experience emotional changes, but no, it's not you. It's most likely what was happening in your head. And I think that warning was really good for the both of us, because I could realize, like, oh, this is not a potential argument. This is actually just him feeling his feels. It's okay. We're going to get through this. So that was a fun, challenging time. But I'm grateful that he's back to normal, because that happened maybe two years ago. What if, so if somebody gets a TBI, is there something like that you should know about how to treat it for themselves?
That's a very good question. I think first and foremost, if you think you have a TBI or brain injury, you need to go talk to a doctor, because there are certain things that you will be able to monitor for yourself, but if your mood is all over the place and maybe you're not thinking clearly, you should have someone else check you out and make sure that you're okay. Most of the time for concussions or mild TBIs, you do not need any imaging. There's nothing that can be seen on a CT scan that would diagnose you any differently than a doctor would just doing a physical examination. But if there's any concern for a bleed in the brain, that's when the imaging needs to be done. So you need to talk to a doctor to make sure that you don't need anything more specific. And in the meantime, I'm going to toss it over to the ER physician, because I'm sure you see this all the time, kind of like the danger signs that we always tell people to look out.
Yeah. So for sure. So again, kind of thinking as a whole. So say if somebody, a little bit older, maybe perhaps on blood thinner, gets a TBI, that is a higher risk for like a brain bleed, something we call hemorrhage, a brain hemorrhage. Certain specific symptom to watch out for. So any new, what we call neurological deficits. So any weakness in one arm, one leg, etc., any numbness anywhere, any changes in vision, changes in sensorium, any what we call altered mental status. So if someone is just not acting appropriately, any paralysis, anything that will make you stop and say, hey, listen, we need to go to the ER. We need to get further testing done. Those are all kind of reasons why you should go to an ER and why you should seek further care. And again, like I said, certain things that will increase your risk is things like blood thinners, older age. If you hit your head and you start vomiting, if you vomit more than 2 times, that necessitates a CAT scan.
Absolutely. Yeah. And when we say blood thinners, we mean things like aspirin or clopidogrel. I'm trying to not use the brand names of the medications. Rivaroxaban, apixaban, those are some of the more common ones, or Coumadin.
Yeah, and then kind of on top of that too, if you're in a major car accident, right, and you get ejected from the car, or say if you fall from a very high ladder, these are what we term dangerous mechanisms in the emergency department, and these all necessitate a CAT scan, or at least going to the ER and getting, further workup.
Okay. Yeah. I'm just thinking back to my boyfriend's journey. So, fun fact, the white shirt that he saved, he got 0 blood on it at the job site.
Very impressive.
Very good.
I lost that shirt when we got the CAT scan.
Oh, no.
I was with him, and I had
Yeah.
just put it down for 1 second, and man, those folks who clean, like, the hospital areas, they're quick. Because we had just walked out of the room, and I was like, oh, no, I forgot the shirt. And he's still in the little hospital gown, and he's like, I need his shirt. I don't have a shirt. I went back, and they're like, we already cleaned it, and they were like, that shirt's gone. And I'm like, I'm so sorry.
Forever lost in the recesses.
Eventually, yes. I let him know I owe you a shirt, so I got him some. But he had to, like, walk out of the hospital with a borrowed jacket, but it looked like an Italian motorcycle jacket.
Oh, wow.
At least you didn't walk out with the hospital gown.
Oh yeah,
That
at
would've
least
been a different
not.
look.
Yeah, I would have been shirtless, or I was like, oh, I'm so sorry.
That's so funny.
Yeah. So now when he tells folks, he's like, yeah, I got zero blood in it. And you know what happened to it? She lost it. I was like, I'm sorry. Yeah. So we talked a little bit about different types of reasons for TBIs and, how to take care of them, how to avoid them. But, when it comes to TBIs, is there, what would constitute brain damage from a TBI?
Yeah, great question. So, I'd say by and large, most TBIs will not cause permanent brain damage. The way I like to think about it, especially with mild TBIs, right, it's just temporary brain injury. Now, certainly if you have a more moderate TBI, you can have more long-lasting effects. But by and large, most TBIs do not cause any sort of permanent brain damage. Now, the danger is when, say, if you have a TBI and you get a second TBI on top of your original TBI, or if you have a TBI and you don't take the right steps to completely heal. In that case, then you can get something called second impact syndrome, or you can get something called like long-term like post-concussive syndrome. These are all things that can last up to years after a TBI. But by and large, most TBIs will not cause permanent brain damage as long as you take the right steps to heal.
And for the more moderate and severe, like let's say you need to get hospitalized for your traumatic brain injury because it's that serious, there's such a spectrum of all the different things that could happen in terms of deficits or, where is the injury located in the brain and all of that. So it's kind of hard to predict what the prognosis is going to be because it's so individualized. But for some people, it can take years and they might need additional therapy or assistance or things like that. But it's a very individual process, unfortunately.
Okay. If you can average them, you're all, I just said it's individual. What about that? Do you not understand? Sorry, it's my inner ADHD monologue. So if you can average the amount of time that it would take for somebody to heal, maybe from like a very moderate to low TBI versus like a more severe one, what are the time windows that usually looks like?
Yeah, so I would say for like mild TBIs, so it does differ in terms of like adults and children, and there are certain risk factors that might put you at a higher risk of having a more long-term kind of symptomatic course, but on average, if you're a healthy adult, typically your symptoms should get better within 2 weeks, 2 to 3 weeks. If you're a child, so under the age of 17, typically it's a little bit longer. It can last up to a month. And I think if you're if you're a teenager, so in between the ages of 13 and 17, you're actually at a higher risk of having a little bit longer of a course, just because your brain is really developing and so causing an injury can kind of offset that a little bit. So on average, again, for adults, about 2 to 3 weeks, children a little bit longer. That being said, for moderate and severe TBIs, again, like Dr. Mercer said, it's very hard to kind of average that, just because every injury to that extent is different, and so everyone's course is going to be a little bit different.
And those are the serious ones might take years to start to regain function, things like that. And with the concussions, those are averages. Sometimes people feel better a lot sooner.
Yeah.
It takes longer.
Yeah, and kind of coming from a sports medicine perspective, so the way when athletes get TBIs and get mild concussions and stuff like that, we do have something called a return to play protocol, which is a minimum of a week. And so there are athletes that we've seen that have gone on this return to play protocol and have actually gone back to doing their activity within a week. And then there are obviously other athletes that have taken a little bit longer.
Okay. What is your opinion when it comes to athletes who don't necessarily listen to the preferred time restriction to go back to their said sport, like we see with football, and how head injuries are pretty common just because of the amount of impacts, with or without the helmets. And what would you say to an athlete who is thinking like they got their TBI, their concussion, and they really want to get back into the game because, you know, there's something happening and they feel like they need to be in it, like they carry the team on their back. And I mean, that's a good part about sportsmanship, but at the same time, you know, we need to be mindful of our own health. And what would you tell athletes?
It's definitely a different type of patient. Like you said, they're highly motivated to return to what they were doing. I think in the past decade or so, we've developed a lot of infrastructure and rules that actually prevent athletes from going back too soon. It used to be, there's always pressure from coaches and staff and things like that to get people back as soon as possible. But I think that there are new rules in place that help the doctor protect their patient, who is the athlete. Meaning, so at a college level, if someone gets hurt in a game and we take them out, they're not allowed to go back in the game. And they have to be out until we clear them within the next week. So that's a hard and fast rule. That's not something that we make up, which really helps us because it takes the pressure off of us and it helps us just be doctors for those athletes. And then in the professional setting, I mean, how do you get people to do anything? You fine them. So there are really heavy fines that are in place if players go back in too soon after having a head injury. So they have these separate sets of doctors that aren't even necessarily affiliated with any particular team that specifically look for those head injuries and do those tests and exams to make sure there's not a conflict of interest and to make sure that athlete is getting the care that they need. So not a perfect system just yet, but there's a lot more in place. And really all you can do is educate them and give them that autonomy to make that decision. But I just remind them that this is your life and your livelihood that we're talking about. And we don't want to do anything that's going to put you at risk or potentially have it so you can't walk later in life or have any confusion or memory loss, and we don't want that for you. And, you know, remind them that our job is to protect you as a person, and you can be an athlete outside of this exam room, but we need to protect you.
Yeah, very well said. Yeah, you know, I think my typical spiel is, and especially for athletes, like Dr. Mercer said, they're kind of a unique population, very highly motivated. They want to get back. And sometimes, you know, and they like to push themselves. And so sometimes they might push themselves a little too far or a little too soon. So my spiel is, you know, a TBI or a concussion is a temporary brain injury. The risk is if you don't let it heal, or if you get another brain injury on top of your already temporary brain injury, you might turn a temporary brain injury into a permanent brain injury. And again, this is your life. This is your livelihood we're talking about. Yes, you know, this game is important, but your life, your livelihood is more important, right? And so, again, educating the athletes on that and just, you know, making shared decision making, I think is very important. That way you know, give the athlete some autonomy, but at the same time, letting them know that you're doing what's in the best interest for their health, I think is very important.
Yeah, well, thank you both for sharing that info. And I've known since I've worked at IHC that we have a residency program, but for you as residents with us, what does the process normally look like? I know that you said you go through a program called Match.
Oh, yeah.
Mm-hmm.
And so what are the steps when you leave your, is it grad school?
Yeah,
and then
medical
school, and then you go through Match, and then you go to a residency program. And what do those things look like?
Yes. So the question is, how old are we and how long did it take us to get here? So after you do college, you go to medical school. So that's 4 years. At the end of your medical school journey, you start applying to residency positions, which is where you do additional specialized training. That could be surgery, family medicine, emergency medicine, something like that. You go and you interview, and then you make a list of your top programs in order of where you would want to go to work. And then you submit that to a computer. Meanwhile, the residency programs do the same thing with all the people who apply to them, and they make a list of their favorite applicants in order of how much they like them. The computer does some magical algorithm, and then on the same day every year, every medical student, fourth-year medical student in the country, opens up a letter that says where they're going. And at that point, it's essentially a binding contract. Mm-hmm. So that's where you find out where you're spending the next 3 to 8 years of your life. So it's a lot of pressure, but it can also be really exciting. Yeah. So, both of us actually, we were in medical school when the pandemic hit. And the pandemic, I think everything shut down the week before our match day. So what is normally a big party for us got condensed. And I think I opened the email on my couch with my husband and my dog. Yeah. But it was really fun.
It was really fun.
It was just a little different.
Just a lot of emotions.
Yes.
A lot of emotions. And so kind of going on that too, so residency is one process, and then there's something called fellowship, which is additional subspecialty training in things like sports medicine, geriatrics, addiction medicine, etc. And so that also is a match process. So very similar to what Dr. Mercer said, you, during your last year of residency or your second to last year of residency, depending on which specialty you're in, you go on interviews to fellowship programs, and you sit down and you rank them. And then the fellowship programs sit down and they rank all the applicants, and then again you submit it to this magical computer that has this magical algorithm. And then again you have a match day where you open up an email or a letter, and it tells you where you're going to be for your fellowship. So
pretty wild.
That's awesome. I mean, you're like, it's a lottery. I don't know where I'm going, but I'm gonna be there.
But it's exciting. Yeah.
Yeah.
And it tends to work out. People tend to end up where they need to be.
Yeah.
I'm glad.
Yeah.
And how has your residency been at IHC? And what was the first day with IHC like?
My first day of residency was at IHC. Mm-hmm. And I think I was only scheduled for 4 patients because I was just this brand new doctor. And it was very, very intimidating. But I remember meeting a patient who went on. She'd been my patient for all 3 years throughout my residency, and she was just very kind and primarily Spanish speaking, and she knew that I was trying to learn Spanish, so she always encouraged me to try to practice without the interpreter with her. But she was so kind and lovely, and she did such a good job of taking care of her health, and she actually, when I was pregnant during my 3rd year, she brought me clothes for the baby because she was so excited, and so that was my first day. I was like, okay, well, this is great. This is exactly what I wanted. And then, every once in a while you get a patient that's really, really complicated, but it's really cool that we get to be able to try to help them as best we can. And I loved working for IHC. So we work either in the clinic at IHC or we work at O'Connor Hospital. So it's nice to kind of come back and forth. And when our clinic patients were hospitalized, we would take care of them there. And it was really nice to have that continuity. So now as a fellow, I'm not in the hospital so much, but I'm still helping take care of patients in the clinic, and it's really rewarding and really fun.
Yeah. So I think my experience was just a tad bit different, just because I was doing a sports medicine fellowship, and so it wasn't like a family medicine residency. So the patients are a lot more specialized. But within the first week, I did do an IHC clinic with, I think, Dr. Mercer this year, and again, I think it's really awesome to be part of the community and to really be a part of, our patients' health and wellness. I also do shifts in the O'Connor ER as an ER physician, and so it's also really cool because I'll see them in the ER, and sometimes they'll be scheduled for the clinic, and so it's you kind of get a little bit of that continuity, not as much as family medicine, but a little bit more. So I think it's really, really cool.
Nice. Since you mentioned having appointments with patients who have language barriers, and then how is that working with interpreters, and what is that process?
Yeah, that's always tricky because it's always a spec. I think the quality of interpreter that we have, we use an iPad essentially. I think the quality is always pretty high up, but every once in a while there's a little bit of a struggle, like the patient might not feel comfortable or the interpreter might miss something, and it's really hard, and I can see the strain that it takes on my patients sometimes, especially if it's a language that's not always readily available on our interpreter surface. So like sometimes Mandarin or some certain dialects that are not always readily available, it's just I can see the strain that it puts on my patients. So I know a lot of my co-residents are in the process of trying to improve their medical Spanish. Just at least we can help with a little bit, but we have a lot of Vietnamese-speaking patients, Mandarin-speaking patients, Punjabi-speaking patients. It really runs the gambit. So we have a number of residents that are fluent in those different languages, and I can see patients' faces light up when they realize that they're speaking with a native speaker who's their doctor. And I think that kind of speaks to the importance of representation in medicine. And so when we talk about the match and trying to find applicants that we want to come to our program, we really are looking for people with that cultural sensitivity, that cultural knowledge, so that we can really help our patients feel the most comfortable. So it's always awkward talking to an interpreter, especially when they can't really see you, and it's just kind of weird and bizarre, but sometimes you do what you got to do, and thankfully most of our patients are really patient, and they're happy that at least some person in the room, even if it's electronic, is trying to help them understand what's going on.
Yeah, like Dr. Mercer said, I think it's definitely always a little tricky with the interpreter, and it can certainly be frustrating. I think, sometimes it can sort of almost depersonalize the conversation a little bit because you're going through someone else, and so it's a little bit harder to make that connection, that personal connection with your patient. That being said, kind of what I found, during my residency and during my fellowship is it's always important to spend a little bit more time with those patients just to make sure that nothing is lost in translation, and just to really make sure that you really try to develop that personal connection. And so, at least just kind of practically speaking, right, when I'm talking to a patient using an interpreter, it's very easy and it's very tempting just to look at the interpreter screen and talk to that, but I think it's very important. And when you're talking to the screen, you're looking at the patient, and you're talking to the patient as if you're speaking in their language, because I think that's that minimizes that loss loss in translation, if that makes sense, and it helps to really personalize the conversation.
I think one of the pitfalls too that I found is sometimes relying on family members who are very insistent, like, I'm going to translate for my dad or something like that, which is wonderful and really kind, but it also puts so much pressure on that family member. So I'm always like, I'm sure you are fantastic at this and you've been so much help, but I'm going to use this third-party interpreter because your job is to be the daughter or to be the son, and you don't need to carry this burden. And I think that's just that added layer. They're trying so hard to protect their family member, and I think we have to be careful with putting that extra pressure on the family members, which I agree. I think we're all guilty of at one point. Yeah.
Yeah, I agree.
Yeah. I have a family or a friend who her mom only speaks Spanish. Well, she technically speaks English, but it's her way of kind of seeing how you are as a person. She'll speak only Spanish to you until she likes you. She's like, I don't know. So she speaks Spanish to you. I'm sorry, she's not her favorite, but it's okay. So her oldest daughter is the one who would be the translator for her most of the time, and like you said, it does cause a strain on that person, and they become they take on that role of being the person who needs to take care of their family. I mean, we all want to try to take care of our families, but it takes the child from being a child and giving them adult responsibilities and the adult stress that comes along with that, and feeling like they need to be the quote unquote savior. And so I think it's really nice to hear that you're taking that extra step to ensure that the child or the family member is just a family member. Exactly. And it's you can speak both languages, but that doesn't need to be your job. I like what you said, that you look at the patient when you're speaking to the interpreter. I work a lot with the deaf community. I was sharing with Dr. Sikina earlier that I have auditory processing disorder, so it makes for fun conversation. Sometimes I'll get things mixed up in my head, and I'm like, wait, did you just say? I'm pretty sure you didn't, but maybe you did. I don't know. And so my brain has to take a little bit of extra work to put the sentences in the right order, and it just makes for fun. But I found that sign language is a lot more easy for me to understand, and I don't mix up nearly as many words, even though a lot of signs look very similar. But I do practice a lot with the deaf community here, and there's interpreters that I get to see out in the community, and we try to make sure that when we have events that are bigger, we have a sign language interpreter, we have Spanish, we have Vietnamese, we have whichever other languages are more common in the area. And then if we're interviewing folks that need interpreters, I also try to be mindful of that, because I hear so often from the sign language interpreters that whoever they're interpreting for tends to look at them. They're like, no, not me, them. And so it's beautiful to hear, as doctor, as physicians, that you are both, making sure that the patient feels heard and seen, and that not all the intention is brought on the person that understands the language that you're speaking. So that's really meaningful, especially to, well, folks in the deaf community, I mean, and elsewhere. But it means a lot. So thank you both. And just one more question, pinky promise. So with the residency program, what does that look like once folks transition? Because from my understanding, I thought we had 30 and like 10 transition a year, or how does, am I wrong?
So right now we have 8 in each class, and there are 3 years. So we have 24 total.
Math.
Soon we will be having more. I think we're going to expand that size, so that's very exciting, because that just means more doctors in clinic, and then you add on the 2 fellows. So there's 24 to 26 of us.
Yeah.
Wow. Yeah. Okay, well, thank you both for making the time out of your day. I feel like I'm stealing you away from your patients.
No.
Yeah, and that's it for our interview today with both Dr. Mercer and Dr. Sikina. Thank you both for joining us at IHC's podcast to talk a little bit about TBIs and IHC's residency program. It was nice to get the inside scoop. So keep an eye out for our upcoming event. We have Mexica New Year, which will be March 15th through 17th, and it's happening at Emma Prush Park in San Jose, CA. If you want to know a little bit more information about that, you can go ahead and click the link. Thank you. Bye.